Now, why do you really require mechanical ventilation? You require mechanical ventilation wherever you have unprotected or unstable airways. Intubation allows you to secure the airway, reduce the risk of aspiration, and to maintain adequate alveolar ventilation. In cases of hypercapnic respiratory acidosis, mechanical ventilation is indicated. Hypoxemic respiratory failure is also another indication of mechanical ventilation. Few others, like apnea, acute ventilatory failure when the PaCO2 is above 50 centimeters, or an impending acute ventilatory failure. The PaCO2 may be normal in cases, but the patient is exhibiting distress, then mechanical ventilation is actually recommended for such patients. Simply put, mechanical ventilation is indicated whenever a patient is unable to adequately remove CO2 and maintain adequate levels of O2 in the arterial blood. Now, what are the goals of mechanical ventilation? Goals of mechanical ventilation are to decrease the work of breathing, increase alveolar ventilation, maintain the AB values, relieve the respiratory distress, and to alter the pressure volume relation. Now, we'll start from some very fundamental. The work of breathing. Work of breathing is work. So, what is work? Work is force, which in this case is pressure, into distance. This, in this case, is a volume. The pressure generated should always be able to overcome the resistance of the airway, should be able to overcome the compliance of the lung and the chest. I will answer any questions that I see on the chat window. There are multiple people asking them. Else, I will answer the questions at the end of the session if that's okay with all of us. Now, the types of mechanical ventilation that we can do. First one is a negative pressure ventilation. Examples of this being iron lung. And then you have the positive pressure ventilator. Could be either volume of pressure or a combination of volume and pressure. Now, if I look at what is a negative pressure ventilation, this is normal ventilation that can be used when we don't have any support. Diaphragm collapses, causes a negative pressure in the lungs. Atmospheric air then rushes in to fill that negative pressure to equate the atmospheric pressure. Once it is equated to the atmospheric pressure, then the diaphragm goes back to its original position by creating a positive pressure to push the gas. That is how all of us breathe. And some of the negative pressure ventilators, like the iron lung, try to mimic this for patients who are otherwise conscious and able to breathe, but for any other reason. Now, these are some of the examples of Emerson iron lung and a product called the NEV100 that's available in the US, where you have chest belt actually pulls your chest up to create this negative pressure. Now, the converse of this is the positive pressure ventilation. In the positive pressure ventilation, your lungs are not able to drop down to accommodate, create a negative pressure. So what has to be done externally is to create a pressure to push the mixed gas into the patient. If I look at the difference between a positive and a negative pressure ventilation on a pressure and volume graph, if I look at a spontaneous or a negative pressure ventilation, the pressure drops. As the pressure drops, the volume increases. In a positive pressure ventilation, you can see that again, the pressure increases, and that is what drives the volume up. Now, let's go to the most common differentiation in ventilation. You have two types of ventilation: volume targeted ventilation or pressure targeted ventilation. The volume targeted ventilation is where preset volume is delivered to the patient. And this is very simplistic. I mean, there could be lots of variations here, but this is very simplistic.
Ganesh, sorry to interrupt. Your voice is breaking bit in middle. So can you keep the mouthpiece closer to the?
Okay. Is my audio slightly okay now?
Yes, it's fine.
Excellent. Thank you for updating. And if the volume breaks off, just let me know.
Yeah.
So in a volume targeted ventilation, the preset volume is delivered to the patient. Once the preset volume is delivered to the patient, the inspiration ends. The volume is constant, the pressure is variable. In a pressure targeted ventilator, it is the pressure that is delivered to the patient. Unlike a volume targeted ventilation, here the pressure is constant, but the volume is variable. And the volumes may increase or decrease in response to the changing lung condition, meaning a more compliant lung will be able to get in more volume than a less compliant lung. Now, if we look at some of the ventilator parameters, I still remember when I started in an ICU many years back, the biggest challenge was that every ventilator had its own nomenclature, and the same thing was being presented in different ventilators as different things. But I'll try and make it simple here. You have a tidal volume, you have a respiratory rate, you have a time relationship between inspiration and exhalation that is called I is to E ratio. Tidal volume, very simply, is the volume of gas in ml that normally moves in and out of the lungs in one breath. Actually, in the lungs in one breath. So the inspiratory tidal volume is the volume of gas that moves in. The expiratory tidal volume is the volume of gas that is then displaced out. But there are various ways that you set the tidal volume. Various disease patterns have different volumes that you can set. The ARDS net protocol says 6 to 8 ml per kg body weight. Another group for non-ARDS patient is also 9 to 10 ml per kg body weight. The respiratory rate, which is also called frequency in some equipment, is the normal breathing rate of a patient. One respiratory rate equal to one inspiration and one exhalation. So normally we breathe at 12 to 14 breaths every minute. If we are having impending respiratory failure, there is a chance that the breath rate increases to compensate. So the equipment in certain modes, you set a breath rate. There is some background noise. Thank you. There was some background noise, so I thought someone wanted to ask a question. So respiratory rate is set at between 12 to 14 breaths a minute, but then it's completely pathology dependent on what kind of respiratory rate you set and what you monitor. The I is to E ratio is the ratio between the inspiration to the exhalation. The normal I is to E ratio is set at 1 is to 2, but again, according to the disease pathology, this can vary. The FiO2 is the fractionally inspired oxygen. In normal room air, we have approximately 21% of oxygen. The ventilators can dial in up to 100% of oxygen. So the percentage of oxygen that you set in the mixed gas that you're giving to the patient is the FiO2. Now, again, we have talked about I is to E ratio, we have talked about rate. But if I have to break the I is to E ratio into each component, the inspiratory time is the time spent in the inspiratory phase of the ventilator cycle. In a volume control ventilation, it could be either determined by the peak flow, or in some machines, you can actually directly set the I time. The I trigger here is how does the machine understand that you as a patient are trying to take a breath? So that is the inspiratory trigger. Some ventilators also have an E-cycle that in spontaneous modes tell the ventilator when the patient wants to exhale out. It is nomenclatured as either E-cycle or E-sensitivity. The peak flow is the maximum flow that the ventilator would need to deliver each breath to the patient. In a volume control ventilation, in some of the ventilators, you set the flow to set the I is to E ratio. In a pressure control ventilation, the flow is normally a variable. Now, let's go to something which is very mandatory to understand and also extremely simple to understand. The difference between modes and breath types, because a lot of youngsters do confuse the modes with the breath types. The modes are how do you deliver a certain breath type to a patient. You could deliver it in a control mode, in an assist control mode, in an SIMV mode, in a CPAP mode, and as one of my friends, Professor J. Johannigan from University of Cincinnati used to say, there are 26 English alphabets, and you could convert them into a mode very easily because there are so many ventilator companies and each one of them want to have their own unique mode. But what is fixed here is the breath type. Is it a volume breath? Is it a pressure breath? Is it an invasive breath or is it a non-invasive breath? So very simply put, the modes are how you deliver the breath to the patient. The breath type is, do you use volume to drive? Do you use pressure to drive? Do you use a mix to drive, or do you drive it non-invasively? Now, let's start with the types of breath. So in the modes, you saw control mode, you saw assist control mode, you saw SIMV, you saw CPAP. So you could either have a mandatory breath, and we will go into these modes in a few slides from now. In the mandatory breath, the breath is started by the machine, is ended by the machine, and no inference from the patient is understood by the machine. So in this case, machine is God. So if you as a physician set a volume of 500, 12 times a minute, 500 ml will go 12 times a minute, irrespective of whether 500 is sufficient for the patient or not, irrespective of whether the patient wants more breath or not. Then you have assisted breath, which is a step which is more synchronous to the patient than a mandatory breath. Here, the breath can either be started by the patient or by the machine. So we'll try and understand more on what is the assisted breath. I'll also show it to you in a graph as to how does the machine understand that the patient is trying to start a breath. But here again, like a mandatory breath, the quantum of the breath, meaning volume or pressure, is still decided by the machine. Now, in a spontaneous breath, the breath is started by the patient, the breath is ended by the patient, and also the amount of volume that the patient draws in or the pressure that the patient displaces is decided by the patient itself. Let's go forward on modes of the ventilatory cycle. So in a control mode, the initiation of the breath is machine, the frequency set. The inspiration could either be flow, which is or volume, or it could be pressure. And the exhalation is again machine set. In an assist control mode, the patient could trigger to inform the machine that the patient wants to start a breath, or the patient has some efforts on their own. The inspiration is either volume or pressure control that you set. And again, here, the exhalation is the inspirated time setting or the volume being delivered to the patient. In a spontaneous breath, you have the patient who triggers. Once the patient triggers, if it's a pressure supported breath, the patient's own effort is supported by the equipment. If it's a non-pressure supported breath, then the spontaneous effort is as per the patient's own work. There is something called a trigger window here that comes into play. Each machine has its own trigger window, but it's normally between 150 milliseconds to 400 milliseconds. If the patient initiates a breath in this particular trigger window, the pressure support gets active. However, if in the expiratory time, if the patient initiates a breath out of the trigger window, then the patient is unsupported. It is the patient's own effort. Now, spontaneous, as the name itself suggests, the patient starts the breath, the patient ends the breath. The quantum of the breath is completely the patient's own. But even in spontaneous, you could have either a pressure support or a volume support.